Hi dear docs, I welcome you all to the RoyalDocline, and today in the 5 minutes guideline series we will be discussing about the management of the sickle cell disease in pregnancy. This is by the British Society for the Hematology, and this is a green top guideline number 52 which came in 2021. This is the new version of this guideline. The layout is a preconception, antenatal, intrapartum, postpartum, contraception, and the summary of this guideline. The preconception includes a screening for the genetics. As a part of the annual review, the partner testing prior to embarking upon the pregnancy, and during the pregnancy you can also discuss about no intervention, prenatal diagnosis or the pre-implantation genetic diagnosis, and the comprehensive review of the complications in such women is very important. It should be discussed at their annual review by a specialist to ensure the optimization of their health, and the screening for the disease complications are important. There should be a preconception clinics. They should be available and accessible. The medication review is very important. These medications include the folic acid 5 mg should be given from before conception, and it can be given throughout the pregnancy. Women should be given vitamin D as per national recommendation. Daily antibiotic prophylaxis is also recommended, and make sure the vaccination is up to the mark, and specifically the flu vaccination. When attempting to conceive, the ARBs and the ACE inhibitors, they should be stopped. Hydroxycarbamide should be discontinued when she is attempted to conceive, unless the woman is considered to be at high risk of the serious complications related with the disease and the blood transfusion is not feasible. Iron chelator should be stopped when she is attempting to conceive. Let's move on to the antenatal care. Along with the antenatal care, you have to take into consideration of the prenatal care. All the things which have been done in the prenatal care, they should also be considered in the antenatal care. And over here, antenatal hemoglobinopathy screening is very important, and the pregnancy-induced hypertension has to be taken care of. So a full assessment as for preconceptional care should be repeated, and everything which you did before, it has to be done. Multidisciplinary team management is important. Women with the persistent vomiting, they should be advised to seek help early. Folic acid should be given. Iron supplementation should only be given if there is a laboratory evidence of the iron deficiency. Consider the low dose aspirin 75 to 150 mg once daily from 12 weeks, and consider to review at 36 weeks of the gestation to stop it before the delivery. Serial fetal growth scans are very important every 4 weeks from 4 weeks of the gestation. Blood transfusion during the pregnancy, the risk and the benefits of the prophylactic transfusion should be discussed with the patient, hematologist, and the obstetricians in the early pregnancy, and consider the following factors: the genotyping and the phenotyping, previous obstetrical history, twin pregnancies, all are very important. Alloimmunization should also be taken into consideration, and screen for the multiple red cell antibodies. If the transfusion is needed, pregnant women, they should be given ABU compatible extended RH and CalMatch CMV negative units. Prophylactic transfusion is not routinely recommended for these women, but they can be considered for the woman with previous or current medical, obstetrical, or the fetal problems, or the woman is previously on the hydroxycarbamide due to the severe disease, multiple pregnancy, and the women who are receiving the long-term transfusion for the stroke prevention or the amelioration of the sickle cell disease complications may continue with the regular blood transfusion throughout the pregnancy. Transfusion may be required in the women with the worsening anemia, and they should be considered for those with acute sickle cell disease complications such as acute chest syndrome or the stroke. The management of the acute pain crisis during the pregnancy is very important, and there should be an agreed management plan for such women, and the multidisciplinary team should be involved, in the NICE guideline for the management of the acute painful crisis should be followed. NSAID should be used with caution in the first trimester and avoid it after 31 weeks of the gestation. Fluid and oxygen balance should be monitored regularly in such women, and always give them the low molecular weight heparin during the antenatal as well as the hospital administration. So let's move on to the management of the acute chest syndrome. Women with an acute chest syndrome should be seen with the vigilance. Always remember that there can be an underlying pulmonary embolism as well. All the hospitals, they should have a treatment pathways for such symptomatology in these patients. Antibiotics to cover the atypical organism should be used even if the blood cultures and the sputum cultures are negative. Simple top-up transfusion should be considered early in the hypoxic patient, but the exchange transfusion is necessary if there are several clinical features or the evidence of the progression despite the initial simple transfusion. So next comes the acute complications, which are acute stroke. It should be considered if the woman is presenting with acute neurological impairment and requires an urgent consideration of the exchange transfusion. Acute erythrovirus infection should be considered in the women who are presenting with acute anemia. If there is a VTE and thromboprophylaxis, it has to be taken into account according to the RCOG Green Top guideline. Then comes the intrapartum care. The timing of the birth is usually 38 to 40 weeks of the gestation. Mode of the birth is not affected by only the sickle cell disease. However, the vaginal birth after a cesarean section can also be offered. Avoidance of the dehydration, keeping warm, and regular oxygen saturation, as well as avoiding the fluid overload, are very important. General anesthesia sometimes carries an additional risk beyond the normal obstetrical care and should be avoided. Regional analgesia is recommended for the cesarean section. Remember this, and review by the anesthetist is very important. Pethidine should be avoided because of the risk of the seizures, and the woman with the sickle cell disease should be advised to give birth in the hospital, and the multidisciplinary team should be involved earlier in the labor. Blood should be cross-matched for the delivery if there are atypical antibodies. Continuous electronic fetal heart rate monitoring is important. If there is a hip replacement because of avascular necrosis of the hip bone, then suitable position for the delivery should be discussed even prior to the delivery. In the postpartum care, the pain management is very important. Low molecular weight heparin is also very important, and the hydration or oxygenation should be maintained, and early mobilization is encouraged. NSAIDs can be given in this postpartum period, and it can be used even during the breastfeeding. Codeine should not be given during the breastfeeding. Dihydrocodeine, tramadol, and other opioids can be used but should be at lowest effective dose for the shorter duration and under medical supervision. Infant should be monitored for the sedation, breathing difficulties, constipation, difficulty in the feeding, and the weight gain. Breastfeeding should be encouraged. Antithrombotic stockings are also recommended in the puerperal time. The contraception advice for the woman with the sickle cell disease. Contraception advice should be given and conveyed to the woman by the primary care team. The choice of the contraception should be individualized, but the methods that eliminate the user failures, such as the levonorgestrel intrauterine system or the Mirena, and the intramuscular medroxyprogesterone, are the preferred one. There is some evidence for reduction in the sickle cell pain are associated with the progesterone only preparation, which means that the people who are using the progesterone preparation, there is a lesser chances for having the sickle pain. Combined hormonal contraceptions are an option for the woman, but however, the cardiovascular risk factor should be minimized to mitigate the potential risks which are associated with these hormonal preparation. I hope so you would like this video, and if you like it, please share it with your friends and subscribe to our channel. And please let me know how are these videos and what other videos would you like me to make for you.